First speaker today, the keynote talk is by Professor Virgilio Carnielli on early predictors of CPAP failure from the Ancona cohort. Take it away.
Thank you, Ram. I'm happy to be with you today and sharing a bit our local experience and our view a little bit on CPAP failure. And I start by telling a little bit and sharing the plan of my talk. I would like to spend a couple of minutes on the background and to learn, because I think we can learn a lot from the past, because there are very interesting studies in the past that change our practice, but there's always a deeper or a better way to interpret these studies. So we'll mention the 5 studies that on RDS and the implication for modern practice. I will sort of discuss with you the CPAP failure is a very controversial issue. We need a standardization. But more importantly, we have to realize, and this is not always emphasized and discussed in the study, that we are dealing with bad babies, mild babies, and good babies that probably in the latter will do well anyways. So this sort of, to me, is a critical issue in interpreting some of the studies. And in the view of this consideration, I will share with you the Ancona experience. However, the final message will be that the bottom line is to get good performance, get a low intubation time, but perhaps more importantly, low BPD rates. And sometimes, we discuss about methods, but we are less into benchmarking and performance. So this is history clearly, but I like to present this slide because it really tells us about the progress we made over the last 5 decades or so. So big dramatic changes. It was in '64 that Maria de Livoria published the first intubation and ventilation of a preterm baby, which was really an exciting new approach to RDS. And from then on, many babies receive a standard treatment who was intubation right after birth because of this. And in no time, 2, 3, 4 years, we have in '67 the first description of by Bill Norway about BPD, and in '67, so 4 years after the first intubation. And this is my booklet from the Toronto Fellowship. You see, it's in '85, November's. And many of the sentences, many of the session in this booklet would say, having intubated the infant and secure endotracheal tube, blah, blah, blah. And that was the starting of many sort of guidelines, booklet, chapter, and so on. It was 10 years ago that several studies, I would say 5 major important studies, changed the way we approach baby with RDS, while no big difference or no big change occurred for the previous 30 years, I would say. So we have the COIN trial, the CURPAP trial, the support trial, the IMV, and the VON delivery room management study. I will say a few words and highlight some of the interesting points of these studies. Well, this is by Colin Morley, where they randomized preterm baby to CPAP or the standard care, immediate intubations and surfactant. So it was 1-to-1 randomization, 2 strata, 25, 26 weeks, and 27, 28. A randomization occurred at 5 minutes of birth. And CPAP was up to 8 centimeters of water. What they did find is that surfactant treatment, because of the study design, I would say, because of the aim of or the purpose of sustaining baby with CPAP without a conventional technique was given to significantly fewer infants in the CPAP group, which is not any longer something we are doing. And this very high probably CPAP value, 8 centimeter, cause a significantly higher pneumothorax rate in the CPAP group. So their conclusion was that both groups had similar outcome at 36 weeks, no difference in BPD. And the sort of cautious conclusion was starting early CPAP in very preterm infant was not detrimental. The critiques were that CPAP was given sparingly in the surfactant, was given in the CPAP group. Fewer baby got coughing, and it was in a selected group of babies. The study that I liked the most, because it's also performed in Italy, but it's a joke, of course, is the CURPAP study, who has the least number of patients enrolled, but it tells us a lot about RDS, in my opinion. The babies were randomized to intubation and surfactant, standard of care at that time, or nasal CPAP. And what happens? Please follow with me what happened to this baby. Whether you get intubation and surfactant, early extubation within an hour, well, in 5% of the cases, baby were stuck on the ventilator here, and they could not be extubated. 94% could be extubated, but among these babies, a significant number exhibit extubation failure, 25% of the total. So at the end of the story, we have 68% free from the tube and plus 25% plus 25 for a total of 31% still in need of mechanical ventilation. If we look at the other group, babies were all stabilized on CPAP. Some baby did well, 50%. Somebody had nearly half had CPAP failure, intubation and surfactant because of failure. 18% were stuck on the ventilator. 13 were extubated with, again, subsequent success or secondary CPAP failure. And if you look at this number at the end of the story, you have a 66% free of tube and 33% of depending on mechanical ventilation. So if you take you put together this information, you could really conclude that it doesn't really matter. At the end of the story, CPAP or surfactant, 33 versus 31 intubation, 67 versus 68. But what is important, it tells us that we have babies with different clinical characteristics that respond differently, and I will come back to this later. Then it was clear that when we talk CPAP failure, we will be dealing in some baby with a primary CPAP failure in yellow here, or we have secondary CPAP failure, like here, after intubation and surfactant administration. And it's important to sort of focus on these two groups. Another interest, so the conclusion of this CURPAP trial was that 63% of the baby, to two-thirds, had to be intubated, while intubation was only 50% in coin and two-thirds in the support. And prophylactic surfactant was not superior to early rescue surfactant treatment. BPD rate, in spite of these very different approaches, was 20% in both groups. And this 20%, please bear in mind, is somewhat lower than in other studies. A BPD rate was 40% in the coin and 50% in the support, and only 20% in the CURPAP trial, in both groups. Then we have the largest study on is the support, nested design, oxygen saturation levels, different saturation targets, and CPAP versus intubation and surfactant. You're all probably familiar with this study. And again, sort of a somewhat disappointing result. 67% of CPAP babies were intubated, again, 2/3, and absolutely similar outcome at 36 weeks in terms of BPD. What is a bit peculiar about this study is that the extubation criteria were a bit conservative, I would say. So you wonder if the advantages of once you get intubated, if you get extubated so cautiously, could have sort of played a role in causing or in explaining this high BPD rate in this particular study. And we are dealing here 24 to 27 weeks. Then we have the German study, the avoidance of mechanical ventilation. And again, here we have the intervention group and the standard group, but please focus here on bronchopulmonary dysplasia. Again, no difference in the final outcome we all care about. This is delivery room management, basically 3 approaches and similar outcome at 36 weeks. It took only a meta-analysis, was conducted in 2013, really to come up with a small, subtle difference. But at that time, the practice, our neonatal practice has changed a bit already. And in this meta-analysis, they put together more than 2,000 babies from the COIN trial to support the CURPAP and the delivery room study. And you can see here the result is meta-analysis. BPD or death was significantly lower, but no different in death and the trend towards lower BPD. According to the calculation, this meta-analysis, you need to treat 25 babies with nasal CPAP to prevent one BPD, one death or BPD, which is a step forward, but probably is not as big as we anticipated. In addition, I like to speculate that if the extubation criteria were of the support trial that, of course, contributed a large number of babies would not be so conservative, the number would have been close to 140 or 150. So it's a step forward, but it's not a marked significant change. However, from those studies, in spite of this sort of, I would say limited because it's too negative a word, but not such a tremendous changes in terms of outcome, the practice of neonatology had changed from that time completely. And from that moment onwards, we have all kinds of studies addressing the issue of CPAP failure. So as CPAP became the standard of practice for baby with RDS, there was a lot of interest in understanding why some baby would fail and some baby would have success on CPAP. I make a list of the significant study up to 2013, then I lost a little bit the count, and I like to comment just a few. Most of the studies shows a bit the obvious, let's say. Shows that if you do well in CPAP, you succeed with CPAP, you don't go into failure, you have better outcome. And this is the study by Amari in Journal of Pediatrics. You see all the severity in the clinical data and the gas exchange data clearly show that CPAP's success is far better than CPAP failure. This study by Ali et al. Again show difference between baby need intubation and baby on CPAP in terms of birth weight, gestational age. And this other study highlight the importance of FiO2 requirement in predicting CPAP failure. All things we are use these days. And the higher your FiO2 and your PCO2, the shorter the time from to intubation. The first study, which is a very popular study, that sort of is kind of comprehensive, look more in a significant number of babies, more than 300, if I remember, was a study by Peter Dagaville in 2013. And he looked at the predictor of CPAP failure, and he looked in two groups, 25 to 28 weeks gestation and 29 to 32 weeks gestation. And oxygen, FiO2 in the first 2 hours in the first group, and FiO2 during the first 6 hours were the most significant predictor of CPAP failure, as you would expect. These are the rock curve in the study by Peter, and you see that FiO2 has a AUC of 83, here 81, and you can see this false positive rate and the false positive rate in the other group, which quite nice and predictive curve. Interesting, there was this other study, went a little bit missing, or they did not draw a lot of attention. This is a study by Anne de Jager, who again compares CPAP failure and CPAP success. And again, clinical, demographic, and severity indices difference between CPAP failure and success. But when they report in their multivariable association in this logistic regression, indeed they find something when they went a little bit missing. It was not emphasized that FiO2 in the first hour and the FiO2 in the second hour greater than 25, which a much lower value than what we use now for intubation and surfactant, had an odd ratio of 10 and 18 to predict CPAP failure. Was a small number of, relatively small number of infants, was Acta Pediatrica 2012. But it was a sort of an interesting point to comment. And again, there are more studies pointing to oxygen requirement, but most of the time the search for the oxygen requirement to be used as a predictor for CPAP failure was not done in a systematic way, like with the decision tree analysis or so. Was more a pragmatic choice. Let's look at 30% and see how much it predicts. Nobody, as far as I know, has really looked at 21, 22 in a systematic search for the best predictor. So until sort of, and as it is now still, we have a poor tools and poor way to predict CPAP failure, because there's no consensus with regards of early predictor of CPAP failure, because patients are very heterogeneous, because of difference in CPAP failure definition. Criteria for surfactant administration are more or less liberal, depending on the country and the setting. And demographic data, or they may vary, not so much in birth weight, but some study enrolled 23 weekers, sometimes they started 25 and so forth. So it's still a kind of confusing area. So we are interested in auditing our data. We are interested in finding out what happened in our own workplace. So we took a bit interest to see what happened in Ancona. And in Ancona, since 2004, we standardize all diagnoses. All diagnoses are given according to predefined criteria in a prospective fashion. And also, there's a good standardization for surfactant administration and for assessing respiratory severity. So we said, let's look at what happened at our institution. So I will report today, I will discuss with you today the results of a 2004-2017 cohort with nearly 1,500 preterm babies between 24 and 31 plus 6 days, but with a birth weight above 400 grams. CPAP failure definition was an FiO2 greater than 40% with a PEEP value at least of 5, respiratory acidosis 720, and CO2 greater than 65 on arterial blood sample, and apnea unresponsive to stimulation and coughing. These are our inclusion criteria, as I will not repeat in the interest of time, 24 to 31, and CPAP, primary CPAP. Exclusion criteria are listed here. Basically, being intubated before, require no ventilation for 3 days, violation of protocols, malformation, incomplete data. So we started from 1,400 babies. 400 were intubated, and 250 were inborn, were not outborn, 838. Additional exclusion criteria here, because of the reason are listed here. So we end up with nearly 600 infants, and in the 600, 264 had CPAP failure, and 321 CPAP success. Few more were eliminated because of protocol violation or intubation for surgical reasons and so forth. So the final number were 252 and 310. And this graph shows the absolute number on the left and the percentage of baby intubated at our institution. In the gray area are the baby that failed CPAP, and the baby in white are the baby that has CPAP success. As you would expect, there is a significant effect on gestation age. The older, the higher the gestation age, the higher the chance of CPAP success, and the lower the chance of being intubated. So when we compare CPAP success and CPAP failure, as you can see in nearly 500, more than 500 babies, we found what all the other had found before. CPAP success babies are larger, healthier, and a better clinical characteristic. You see, gestational age is 31, 29.8. So it seems biological trivial, but is statistical significant. Prolonged rupture of the membrane is different. Cesarean section rate is different. We have very high cesarean section rate, as you may notice. Antenatal steroids, 99 versus 95.6. It's also very high antenatal steroids rate. And in terms of outcome, everything is different. Most of the things are different. Duration, mechanical ventilation, pneumothorax, BPD, PDA, neck is not different. IVH greater than 2, 3, and 4, death, and BPD of death. So we are dealing with two separate group of babies. These are the same data with an histogram, and what you see what the statistical differences are. But basically, it's a graphical representation of the numeric data in the previous slides. What struck us when we look at this data from Ancona and our cohort, unlike, we came a bit unexpected, we found that intubation and CPAP failure occur at a much later time point in a significant number of babies than what we expected. We would expect that most babies would fail by 3, 4, 5, 6 hour life. But here we have a bunch of babies that eventually had CPAP failure at later postnatal age or postnatal hours later. So we look at we did a bit of the same work that Peter Dagaville did. Luckily, we had twice as many babies as Peter. And we look at our FiO2 curve, FiO2 value as a predictor of CPAP failure. But we did it in a different way. We did this decision tree analysis. So we did it with a very complex mathematical model We look at any FiO2 above 21%, 21, 22, 22, up to 40. We look for each FiO2 in a model for at a different postnatal age in hours. And we found out that the best predictor with this decision tree analysis was FiO2 equal or greater than 23, please note 23, between 180 and 240 minutes, between 3 and 4 hours of life, which we like as a concept because it's the time that it normally takes to really fully stabilize a preterm infant. We look here at the ROC curve in all baby 24 to 32 weeks, and we find a area under the curve of 0.86, accuracy 81, sensibility 84, specificity 80, so very high numbers in nearly 600 babies. So we look also at baby 24 to 29 weeks, so the younger, let's say, babies, area under the curve 0.90, 84, 88, 84 for accuracy, sensibility, and specificity, respectively. We look at 29, 32 weeks, so the larger babies that experience CPAP failure in a significantly lower proportion. But again, if you look of the predictor of those who failed CPAP, were quite similar. Again, FiO2 greater or equal to 23, but 180 to 140 minutes. Area under the curve 0.84, 80, 82, 79. And interestingly, because this study, we took a significant number of patients, 600, but it spanned from 2004 to 2017. So we also wonder whether this model or this would have been true in the first years as compared to the latest year of the study. So we applied this model for the year 2004-2009. Of course, we have half patient year, but again, surprisingly, the model hold true also in the previous decades. And we looked, of course, in the 2010-2017, half of the patient, but again, the same model, true again. So you may interpret this as a weakness of the study, or you may interpret as a strength of the study, because if the same models applies and these high percentages across a longer period without significant changes in clinical practice, there must be some good in it, some truth in it. So we took interest in comparing our curve in black with the curve of Peter. You can see here, our curve has somewhat a better fit, a higher true positive rate, possibly also because of the large number of infants. And this is for the old babies, for smaller babies. And this is our curve in black compared to Peter Dagaville in blue for somewhat older babies, 29 to 31 weeks. Well, we did, of course, multivariate logistic regression for CPAP failure. And what we found, if we take the old babies together, nearly 600 babies together, you find that gestational age is significant, is a predictor. No surprise, as the segment, the range, go to 24 to 31 weeks. Birth weight is not significant, but FiO2 greater than 23 at 180 to 140 minutes of life is highly significant, and there is a tendency for prompt to be protected. If we take the smaller babies, 24 to 28 weeks, probably gestation age is not any longer significant because we narrow the gestation age range. Birth weight becomes significant, but FiO2 has an odd ratio 34, huge number here, 34. So it's highly predictive of CPAP failure. And if we take the larger babies, again, FiO2 odd ratio 13, NP-PROM is significant. So among all the clinical variable, let's say, FiO2 greater than 23 from 180 to 200 min was found to be a very strong, significant predictor of CPAP failure across the different groups with the different models. So our conclusion that FiO2 can early predict CPAP failure, and early we mean 180 to 140 minutes, and FiO2 greater than 23 is a good predictor both for the whole group and for, but also it holds true from 24 to 31 week. Is that a surprising finding? We don't think so, because we are convinced that either you get RDS or you don't have RDS. What many people think is that RDS is milder, is somewhat milder in the larger baby. But we don't think this is the case. We think the case is that RDS is less frequent in older babies. It's not necessarily milder. It's the way we look at the disease. So this is sort of probably a finding, interesting, or a matter of discussion, if you have the question. So I come to my last slide. And by looking at this sort of distribution of, let's say, late, or looking at this significant number that got late surfactant treatment, a late CPAP failure, we thought we apply this model, this logistic, to see what would happen if we had used this model for intubation surfactant administration. So our models tells us that had we chosen to give surfactant intubation and diagnose, let's say, CPAP failure between 880 to 140 minutes, and we proceed to intubate and give surfactant, surfactant non-invasively, we would have treated 11.2% of the patient unnecessarily, which is, of course, is an issue. But from the other side, we would have treated nearly 28% of the baby at a much earlier time point after birth, on average several hours, but for several people. And you all know that the early surfactant, the early you give the surfactant, the better. So we are stuck at this point. We don't know the pros and the cons of these two considerations that comes after the application of our model. This is my last but one slide. We are now busy with a few study, and now we are randomized the baby to get surfactant in the view of this finding, either with 23% oxygen versus 33, and will be a randomized study. Of course, we are busy with LISA insurers and non-invasive surfactant ventilation. This is the clinicaltrial.gov registration of our medium versus low oxygen pressure for surfactant administration. This is the other study where I compare LISA and insurers without sedation, with and without sedation. And this is a nested design. I come to an end. I thank you for your attention. This is, I'm sure it's a controversial, this finding from Ancona. I hope they will raise some questions, but I like to remind you that bottom line is here, because we get the bad babies, we get the mild babies, and we get the good babies. Sometimes we love the technique, we fell in love with, something, but the bottom line is you have to look at your death rate, your BPD rate, and your death plus BPD rate. And I would strongly like to compare with you, or suggest that we compare, because if your BPD rate in a given population is 50%, there is something wrong with there's something to be improved. If your BPD is 20 or so, you are in a better shape, no matter what your style of care is. So whether this is going to be replicated in our institution, I don't know, but I think This is our local experience, as you know. I'm very fond of local practice, clinical auditing locally, and develop a strategy based on your risk factors, your own local risk factors. Thank you for your attention.
Thank you, Professor Corneli, for an elegant review and your experience in Ancona. Couple of questions I have before I see anything from the audience. When you're comparing Peter Dargaville's study in Australasia, as you know, they use a much higher CPAP of like 8 centimeters in most of the babies in Australia and New Zealand. What was your CPAP level that you used in your NICUs routinely beginning?
Well, we start between normally with 3, and we go up at let's say up to 5, and we don't declare or we don't state there is a CPAP failure until we reach at least 5. We are given that our babies have a very high antenatal steroids rate, like 98%, 97% or so. We're not so convinced that we did some physiological study, but I don't want to waste a lot of time to see how much the oxygen FiO2 gradient or the SFR would improve by increasing the the CPAP, the PEEP value or the CPAP value. So let's say we go up to 5, hardly we get 6 for primary CPAP failure. And if we don't get any improvement above 5, we don't go much higher. Because of the coin trial experience, where if you go with 8, you have much higher pneumothorax rate. And because we saw by measuring, maybe I can share with you some, let me see if I can still share. We have this system here. Let me see.
While you're looking for it, the coin trial babies were actually on room air, majority of them, right? So
Yeah.
that's why they had 4.5-fold increased risk of pneumothorax, 2 versus 9%. Right?
So there is, maybe I'm a bit too long. You see my slides, we have this system with full pulse oximeter, and we look what happens if you increase PEEP value by having a very reliable values of pulse oximeter. We get the average of 4, and we don't get any benefit of going at a much higher level of PEEP. We don't know the explanation, and the risk of over expanding a baby that don't have a significant collapse is there probably, or don't have a significant respiratory failure, in our view, is there. And I don't remember now by heart, but our pneumothorax rate is 2.5%, 3% or so. So it's not that great. So
okay.
I have no precise or no clear answer to your question, but we don't like, unlike CPAP, like extubation, CPAP after extubation, there we go up to 8, as Eduardo study shows in Journal Pediatrics, and there we try to go to higher level. But for primary CPAP failure, we stop at 5.
Okay, Professor Oleg?
Virgilio, thank you for your great results. And my question is, don't you think that we have to think over about to returning back to prophylaxis surfactant? Because you show, first of all, you show quite huge amount of babies who are failed CPAP, and we could help them by prophylaxis of surfactant, I think so. And also you show babies who were failed and who received surfactant treatment too late. Because I think that we have some new trials and some new reassess this idea that extremely preterm baby almost all requires surfactant. What do you think about it?
It's difficult. I mean, something I stayed away, I did not touch today was the use of ultrasound, whether with ultrasound you can get even better prediction that is FiO2 values, but it's kind of clear, in my opinion, that, well, that we have bad babies, mild babies, and good babies. Possibly we have to improve the clinical diagnosis of severity, and we have to start thinking that not all the babies are the same. So I'm making a special effort now to work out these three group of babies and try to individualize the treatment depending on this sort of three groups, which I sort of illustrated in this CPAP, in this CURPAP trial. Returning to your question, it's possible there could be local differences, difference in rate of chorioamnionitis from center to style of care or so. I cannot comment, and I will be cautious to extrapolate my finding in Ancona, but the next step is here. I'm really convinced that we should have a randomized study, which I started 2 years ago, 1.5 years ago, where the baby should receive surfactant if indicated. So, I mean not if you are asphyxiated or so, at the medium or low oxygen threshold. And my proposed value, as I indicated, here they are, is 23 versus 33. We have a good system to measure subclinical BPD now, and we hope with the number we are able to recruit, we are able to find some difference in outcome. So if our hypothesis is true that the earlier you treat, the less damage or the better the outcome, it will be almost impossible these days to show a difference in BPD, especially in a center like ours, where we have 22, 23% BPD, even between 24 and 26 and 27. So it will be very difficult, really, in my opinion, to show that you are able to decrease significant these things. But by using some proxy oxygen diffusion, I'm convinced that you could eventually demonstrate some slight improvement in oxygen diffusion. This is what we are after now. So forget about BPD, too difficult, and try to improve oxygen diffusion. Sorry, Ram?
No, David has a question. David?
I was just going to point out there's a question in the chat from Lizelle, and probably this should be the last question because time is up, but how does the method of giving surfactant, i.e. Ensure, Lisa, or Mist, influence the choice of FiO2 at which surfactant should be given, or should they all be the same?
My opinion, they should be the same. As the matter of fact, this is the second study we are busy with, and we are randomized Lisa versus Ensure with and without sedation, and we look at peridosing events and so forth. So honestly, I don't think that we have enough evidence to recommend a different threshold for surfactant administration depending on a perceived difference in the sort of the administration method or so. So I would be cautious. Maybe there is something, we should do more research on this, but I would not start with I would be to have a lower threshold for a technique which is not demonstrated as yet to be less invasive.
Okay, well, thanks very much. I think we better stop the first session there and move on now because they were 5 minutes behind, and we'll progress on to the next session, which is a workshop on lung protection strategies from the delivery room to discharge. And this is going to be a series of 3 pre-recorded lectures. First is going to be Professor Oleg Ionov talking about lung protection from within the delivery room. Then Professor Mark Prutkin is going to talk about ventilation strategies for lung protection. And then we're going to finish with me giving some guidance on the pharmacological approach to lung protection. And then we'll hopefully be able to take some questions at the end of all 3 of the talks. Thank you.
Экран виден, презентация видна. Меня видно, слышно?
Да-да, вас слышно, все в порядке.
Я приношу извинения перед своими зарубежными коллегами за то, что я буду говорить по-русски. Дело в том, что в чате мы посмотрели, там все-таки больший процент подключений русскоязычных, и из-за уважения к большинству было принято решение поговорить по-русски, поэтому я прошу прощения. Мы сегодня с вами поговорим за полчаса много не охватите, мы поговорим сегодня о отсроченном пережатии пересечения пуповины, мы поговорим о температурном режиме в родзале. Да, я не сказал, что Дэвид анонсировал, что моя речь будет исключительно о истории про родильный зал. Далее мы с вами поговорим про как стартовать, с какой респираторной терапией, СИПАП или интубация, и немножечко поговорим о сурфактанте. То, что касается отсроченного пережатия и пересечения пуповины, мы с вами знаем, еще где-то в 60-е годы прошлого столетия было показано, что объем крови между плодом и плацентой распределен где-то примерно в отношении 1 к 1. И уже к концу беременности это соотношение переходит где-то 2 к 1. То есть в случае пережатия пуповины сразу после рождения где-то около трети крови остается в плаценте. И если пережать пуповину спустя 60 секунд после рождения, то кровь успевает трансфузировать к ребенку, и плацента запустевает почти на 80%. Это известные факты. Более того, известно, что сам сосудистый бассейн плаценты, он имеет такую особенность, он характеризуется очень низкой резистентностью и очень высокой растяжимостью, и принимает на себя где-то от 30 до 50% сердечного выброса плода. И когда мы с вами внезапно переживаем пуповину и прекращаем плацентарную трансфузию, то тем самым мы резко возрастает постнагрузка, и из-за того, что идет сброс, лево-правый сброс по артериальному протоку, возрастает еще и преднагрузка. И было показано в 2013 году, в Бхати с авторами, было показано, что он наглядно продемонстрировал на ягнятах, что гемодинамический эффект вот такого немедленного пережатия заключается в том, что где-то в легких на 50% падает кровоток, и резко снижается где-то на 40% частота сердечных сокращений. Вот все эти патофизиологические предпосылки легли в основу, можно сказать, реинкарнации вот той технологии, которая говорит о том, что желательно пуповину пережимать и пересекать позднее, чем как можно позднее. В литературе на самом деле нету четкого определения, что такое отсроченное пережатие пуповины. Есть во всех исследованиях сравнивается либо немедленное пережатие пуповины или в течение первых 30 секунд с пережатием, пересечением пуповины уже спустя 30 секунд. Поэтому от 30 секунд и выше это уже считается отсроченным пережатием. И что мы знаем на сегодняшний день? Исследований было проведено очень много, и на сегодняшний день мы знаем, что при отсроченном пережатии пересечения пуповины где-то около 30 мл на килограмм крови попадает из плаценты к ребенку, и это, соответственно, повышает концентрацию железа у ребенка и, соответственно, дает более высокие цифры гемоглобина. Этот эффект длится до полугода, и это, соответственно, снижает потребность в трансфузиях у недоношенных новорожденных. И в некоторых исследованиях было показано, что также и снижает частоту внутрижелудочковых кровоизлияний. Вот недавнее исследование в 2021 году, это не исследование, это систематический обзор, было показано, в этом систематическом обзоре было показано, что отсроченное пережатие и пересечение пуповины улучшает несколько выживаемости. Несмотря на то, что, как здесь видно, доверительный интервал чуть меньше единицы, но все равно автор обращает на внимание к тенденции к этому процессу. Причем, чем дольше проводилась эта процедура, я имею в виду, чем дольше принималось время дольше было время экспозиции отсроченного пережатия, тем шанс и вероятность выживаемости было выше. Ну и то, что для нас является, на мой взгляд, наиболее интересным моментом, это то, что у детей, дети, у которых была проведена вот эта процедура отсроченного пережатия и пересечения пуповины, они в меньшей степени требовали поддержки кардиотоническими и вазопрессорными препаратами. У нас в стране, как знают наши коллеги, которые живут в России, указано, что необходимо проводить эту процедуру. Это было еще утверждено акушерским порядком в 2012 году. В нашем методическом письме, которое вышло в прошлом году по реанимации и стабилизации состояния новорожденных в родильном зале, нам рекомендовано проводить эту процедуру, и указано, что эта процедура проводится в случае, если ребенку или матери нет необходимости в оказании какой-то немедленной помощи. Это раз. И второе, если пульсация пуповины больше 100, а это определяет акушер, который принимает роды. Пальпаторно, накладывая там пальцы на пуповину, глядя на секундную стрелку, смотрит на предмет за 6 секунд умножает на 10 или за 10 секунд умножает на 6. Если брадикардия, если падает сердцебиение меньше 100, то, соответственно, такой ребенок должен быть немедленно отдан неонатологу. Ну и на сегодняшний день мы знаем, что все-таки одной из самых перспективных технологий это является отсроченное пережатие и отсечение пуповины после начала или одновременно с началом респираторной терапии. Потому что когда ребенок начинает дышать, и это было тоже показано в ряде исследований, когда ребенок начинает дышать, пул малого круга, сосудистый пул увеличивается, и больший объем крови ребенок может воспринять это более физиологично. Что касается сцеживания пуповины, что мы знаем на сегодняшний день? Ну, во-первых, ее рассматривают, эту процедуру, как альтернативу отсроченному пережатию пересечения пуповины, когда ребенку или матери требуется немедленная процедура, какая-то немедленная помощь, это раз. Во-вторых, мы знаем, что чуть меньшее количество крови попадает плацентарное к ребенку во время этой истории. Ну и есть такая технология, как сцеживание уже отсеченной пуповины, где-то 25 сантиметров, когда эта манипуляция производится уже в процессе оказания реанимационной помощи в рамках начальных мероприятий, когда ребенок уже находится на реанимационном столе. Но на сегодняшний день известно, что, во-первых, эта процедура у детей глубоко недоношенных, это было показано, правда, в одном исследовании, но это исследование настолько всех впечатлило, что эта рекомендация не использовать эту технологию у глубоко недоношенных детей, она на сегодняшний день существует. И она заключается в том, что предпосылки ее в том, что у детей экстремально недоношенных 23-27 недель гестации возрастает частота тяжелых внутрижелудочковых кровоизлияний при сцеживании. Ну, наверное, оно и понятно. Мы с вами знаем, что любые болюсы, они могут вредить, могут нарушать гемодинамический статус ребенка, и поэтому сцеживание пуповины можно расценивать как такой же болюс. Но, тем не менее, этот вопрос остается на сегодняшний день не окончательно, скажем так, утвержденный. Нужно еще дополнительные исследования, потому что мы знаем, что в Японии проводят только сцеживание пуповины, и частота внутрижелудочковых кровоизлияний в этой стране самая низкая, если сравнивать со всем миром. Собственно говоря, требуется дополнительное исследование, и в нашем методическом письме, как уже было сказано, эта процедура сцеживания, она может быть включена в локальные протоколы для использования в отдельных ситуациях, может быть, у не экстремально недоношенных пациентов, а у более старших при тяжелой асфиксии и так далее. Что касается температурного режима, ну, очевидно на сегодняшний день, что холодовой стресс – это ситуация, при которой могут развиваться тяжелые патологические процессы у новорожденных, и у доношенных, и у недоношенных, его следует избегать. И на сегодняшний день исследование показывает, что оптимальным, и рекомендации говорят о том, что оптимальный температурный коридор с рождения у ребенка – это 36,5-37,5 градусов. И снижение на градус вне этого диапазона приводит к увеличению вероятности смерти на 28%. И здесь из этой истории следуют практические рекомендации таковы, что, во-первых, следует мониторировать температуру тела ребенка на всем протяжении всех мероприятий в родильном зале. И датчик температурный имеет не меньшее значение, чем датчик сатурации или датчики ЭКГ. Вопрос, куда накладывается этот датчик, он на самом деле не решен, в паховую ли область, под мышкой, за спину, на грудь. Здесь вопрос неоднозначный, и здесь могут рекомендовать разные центры по-разному, но температуру следует мониторировать и делать все возможное, чтобы поддерживать эту температуру в указанном диапазоне. И очень важный показатель – это температура поступления, температура тела, с которым ребенок поступает в отделение реанимации, потому что она является предиктором, ну, во-первых, качества выхаживания, а во-вторых, предиктором исходов у этих детей. Очень важный момент, который обговаривается уже не один год, но и требует, мне кажется, еще усиления, так сказать, внимания к этому вопросу, это использование увлажненного, подогретого газа, газовой смеси при проведении реанимационных мероприятий. Что касается стартовой респираторной терапии у детей в родильном зале. Но на сегодняшний день, и это очевидно, и мы не обсуждаем этот вопрос, потому что он уже много раз обсужден и доказан, что использование СИПАП у детей в первые 15 минут жизни, у детей 32 недель, снижает потребность в дополнительной искусственной вентиляции и способствует нормализации дыхания. И профилактический СИПАП в сравнении с искусственной вентиляцией снижает потребность в искусственной вентиляции, в сурфактанте, и также снижает риск бронхолегочной дисплазии или комбинированного исхода бронхолегочной дисплазии или смерти. И ЛКОР на сегодняшний день, и международные рекомендации, и наши отечественные рекомендуют у детей, которые имеют спонтанное дыхание, использовать СИПАП, а не искусственную вентиляцию или тем более интубацию. Это же рекомендации нашли отражение в нашем методическом письме, и более того, у нас прописаны некие критерии неэффективности СИПАП как стартового метода, при котором мы оцениваем степень выраженности дыхательных нарушений и потребность в дополнительной оксигенации спустя 10-15 минут жизни уже на фоне СИПАП. То есть есть некие признаки, которые говорят о том, что этот ребенок все-таки нуждается в следующем уровне респираторной поддержки, например, если это недоношенное введение экзогенного сурфактанта. Но что касается детей, у которых дышат, это все понятно. А вот что вопрос на самом деле на сегодняшний день открыт не в плане рекомендаций, а в плане исследований. Что делать, если ребенок не дышит? И мы с вами были свидетелями, как очень долго, и я считаю, что, я не думаю, что этот вопрос закрыт, хотя если он считается закрытым, он закрыт некорректно, и я объясню почему. После того, как мы выяснили, что по результатам систематического обзора Кохрановской базы данных, которая была проведена, было показано, что продленный вдох как маневр который бы мог бы расправлять легкие, снижать, улучшать комплаенс, и как следствие при расправленных альвеол ребенок может, его попытки самостоятельного вдоха могут стать более эффективными. Эта технология была предложена очень давно, продленный вдох. Так вот, было показано, так сказать, на основании анализа ряда исследований, что продленный вдох не имеет преимущества перед там, масочной вентиляцией и так далее. Но в основном, если мы посмотрим на все эти исследования, мы увидим, что продленный вдох проводился в этих исследованиях неоднократно, когда ребенок там не дышал, а дважды или даже трижды. И вот по моему глубокому убеждению, вот эти повторные маневры продленного вдоха, они могли не только, так сказать, улучшать стабилизацию функциональной остаточной емкости легких, но также приводить к повреждению легких, что в свою очередь нивелировало те преимущества вот этого маневра в ряде исследований. Потому что если мы посмотрим и представим себе спавшиеся альвеолы, начинается продленный вдох с высоким цифром пикового давления. Какие-то альвеолы могут раскрыться, какие-то нет. И когда выполняют повторно продленный вдох, то куда будет распределяться поток и, соответственно, давление? Понятно, что не в это законы физики. Не в спавшейся альвеоле будет распространяться это давление, где очень высокая резистентность, а в резистентность и, соответственно, очень высокий комплайнс. А будет это давление распространяться в те альвеолы, которые уже были открыты, что может приводить потенциально к их повреждению. И вот если мы посмотрим исследования, которые вошли вот в этот метаанализ, мы увидим, что везде практически второй продленный вдох был произведен, причем с давлением даже большим, чем давление, которое использовалось при первом начальном продленном вдохе. Практически возьмите любое исследование, и везде вы увидите аж до 30 сантиметров водного столба проводилось повторные, вторые или даже третьи маневры продленного вдоха. На мой взгляд, говорить о том, что продленный вдох там не является эффективным или он там приводит к каким-то результатам, там, говорить некорректно. Можно говорить о том, что множественный продленный вдох, проведенный несколько раз, там, не имеет преимущества перед этим. И одномоментно проведенная какая-то инвазивная процедура при закрытых легких, спавшихся легких, не спавшихся, а при легких, ребенок, который не дышал, это не то же самое, что эта процедура, проводимая многократно. И вот исследование, которое было проведено в Хариш-Кирплане, которое говорило о том, что у детей с экстремально недоношенным показал, этот маневр приводил к смерти. Там как раз было написано, что он проводил этот маневр дважды. И риск повреждения легких у детей там 23, 26, 27 недель, конечно, выше, чем у детей, которых с большим гестационным возрастом. И, конечно, эффект от инвазивной процедуры, проведенной дважды, может существенно отличаться от эффекта, который от процедуры, проводимой однократно. Поэтому мое глубокое убеждение, что необходимо больше исследований, которые касаются исключительно однократного проведения продленного вдоха, как маневр, который расправляет легкие, и дальше уже, не получается, мы проводим масочную вентиляцию, у кого-то этот вопрос получается. А что мы имеем на сегодняшний день, вот какую информацию по поводу однократно проведенного продленного вдоха? Мы знаем, что вот в позапрошлом году было проведено исследование, где было показано, что 15-секундный продленный вдох у детей, у недоношенных меньше 34 недель, в сравнении с 2-3-кратным вдохами, которые сейчас, не 2-3-кратно, а 2-3-секундными вдохами, которых сейчас рекомендуют в современных рекомендациях, простите за тавтологию, было показано, что продленный вдох приводил к тому, что у детей быстрее возникало самостоятельное дыхание. Посмотрите, 3,5 секунды versus там почти 13 секунд. И продленный вдох ассоциировался с более короткой длительностью искусственной вентиляции легких. И я хочу сказать, что мы проводили ретроспективные исследования в нашем учреждении, в Кулаковском центре, где было обследовано 341 новорожденный, и было показано, что в тот период времени, когда мы использовали продленный вдох, мы видели, что действительно в 2 раза ниже была потребность в интубации в первые 48 часов. Это не приводило к повышению частоты внутрижелудочковых кровоизлияний, пневмотораксом и бронхолегочной дисплазии, и не было ассоциировано с высокой смертностью. Понятно, что это исследование ретроспективное, и более того, здесь выживаемость у детей в период, когда мы использовали продленный вдох, была выше, чем тогда, когда мы использовали ИВЛ-маской при старте, когда дети не дышали. Понятно, что на выживаемость влияли совершенно, кроме этого продленного вдоха, масса других показателей, но, по крайней мере, это точно совершенно у нас не было ассоциации с повышенной смертностью. И на сегодняшний день европейские рекомендации говорят о том, что все-таки вот по имеющейся доказательной базе, или я бы сказал так, как ее привыкли сейчас интерпретировать, все-таки если ребенок не дышит, классические методы респираторной терапии – это вентиляция маской, но все-таки не стандартная вентиляция, а первые 5 вдохов с 2-3 секундной задержкой проводить имеет смысл, это стабилизирует функционально остаточную емкость легких, а дальше уже проводится респираторная терапия в зависимости от ответа ребенка. Но при этом в нашем методическом письме мы понимали, что на сегодняшний день на самом деле нету убедительных каких-то доказательств о преимуществе того или иного метода стабилизации, респираторной стабилизации недоношенных детей. Мы говорим о том, что если технология имеет место жить, она, скажем так, имеет хорошую степень доказательности, если эта методика зафиксирована локальным протоколом, мы можем использовать и продленный вдох, и высокие цифры СИПАП с уменьшением давления на старте, и наоборот увеличивание давления СИПАП на старте, и с оценкой имеющихся результатов, и дальнейшей оценкой эффективности проводимой респираторной терапии. Но это должно быть закреплено в локальных протоколах. У нас в нашем учреждении мы используем концепцию ту же самую, стартовую, не вентиляция, а расправление легких, но используем не продленный вдох, то есть не блокаду клапана выдоха, а метод СИПАП с достаточно высокими цифрами давления, в зависимости от ответа ребенка, с переходом на ту или иную респираторную терапию и с дальнейшими, так сказать, интервенциями, которые требует ребенок. Что касается сурфактантной терапии, ну, много за оставшиеся 7 минут сказать невозможно, я лишь обозначу крупными мазками ту историю, которая на сегодняшний день у нас, ну, срез той истории, которая на сегодняшний день у нас есть. Ну, во-первых, что касается профилактического versus лечебного введения сурфактанта, все-таки ориентируясь же на исследования, которые ориентировались на заключение исследования, которое было Кохрановское исследование, Кохрановский систематический обзор, где было показано, что лучше стартовать с СИПАП, а потом, если ребенок ухудшается, уже давать ему сурфактант. Там же было показано, что результаты этого исследования не следует экстраполировать на всю популяцию недоношенных детей. Потому что эти недоношенные дети, которые были включены в эти исследования, матери их наблюдались изначально в перинатальных, еще были включены в исследования до рождения. Там был высоченный процент охвата антенатальной профилактики стероидами. Народу приходила подготовленная бригада неонатологов и так далее, и так далее. Воспроизводимость этих условий в реальной жизни не очень высокая. И в этой связи, особенно в России, в этой связи мы, как и, кстати, ряд других стран, мы все-таки сохранили для себя концепцию, что проведение, профилактическое введение сурфактанта все-таки целесообразно и целесообразнее, потому что большой процент детей вследствие все-таки ухудшается и переходит требует введения сурфактанта. А мы знаем, чем позже введен сурфактант, тем хуже результаты и больше осложнений. Вопрос поэтому для Российской Федерации пока он таков. Но метод введения сурфактанта, в общем, тоже на сегодняшний день обсуждается, но с тех пор, как Тецуи Саяма несколько лет назад опубликовал очень хорошее масштабное исследование, метаанализ, где сравнивал различные варианты респираторной терапии и доказал, что малоинвазивное введение сурфактанта является наиболее предпочтительным. Этот метод прочно вошел в нашу жизнь, завоевал доверие уже у большинства. Единственный вопрос уточняется, кому, когда, как и прочее. Но любопытно, вот он сам Тецуи Саяма, любопытным является единственный факт, что вот в Токийском университете, в госпитале при Токийском университете и вообще в Японии эта методика, она, несмотря на то, что сам японец доказал, что она имеет преимущество, она до сих пор не принята по той простой причине, это довольно такая веселая ситуация, по простой причине, что японцы считают, что результаты, которые были опубликованы в исследованиях, где была проведена лиза, выживаемость, внутрижелудочковое кровоизлияние, они все равно хуже, чем в Японии. То есть пока японцы даже при своих подходах, которые, в общем-то, с нашей точки зрения, они где-то датируются 15-летней давности, эти подходы свежести, то есть там интубация, сурфактант по показаниям довольно при высоких процентах кислорода. Но тем не менее, там, используя какие-то свои другие подходы, в частности, управление гемодинамикой, коллеги наши получают результаты по выживаемости и по внутрижелудочковым кровоизлияниям, по крайней мере, тем данным, которые публикуют, лучшими в мире. И поэтому они говорят, вот когда мы увидим, что в Европе, в общем-то, приблизится к этому, тогда мы тоже перейдем полностью на и респираторные стратегии европейские. Я хочу, завершая вот свой блог по родзалу, я хочу два слова сказать о препаратах сурфактанта и, в частности, о том метаанализе, который был опубликован в 2020 году, а проведен там в 2019 году. И хочу сказать несколько слов, собственно, для тех, кто привык там не читать весь анализ и вникать в детали, а читать название и заключение. И вот если читать просто название и заключение, то мы увидим, что заключение будет гласить такое, что, так сказать, парактант versus вирактант, они не имеют никакого различия ни по исходам, ни по каким другим критериям. И возникает тогда вопрос. В 2015 году Сингх проводил метаанализ, в котором он показал достаточно выразительные различия, а сейчас их не стало. С чем это связано? Ну, наверное, очевидно, не с тем, что два автора из этого метаанализа – это работники ЭБВИ. И это мы понимаем прекрасно, что, ну какая разница, статистическая обработка может проводиться кем угодно, и это никак не является дискриминацией этого анализа, но тем не менее, в чем же все-таки дело? И вот если углубиться в этот метаанализ, можно увидеть, что, во-первых, смертность была, в отличие от предыдущих метаанализов, была как маркер отмечена не к 36-й неделе постконцептуального возраста, а к 28-му дню. Это раз. Во-вторых, мы с вами привыкли, что поскольку по исходам и, скажем, по выразительности этих исходов в основном в исследованиях объединяют смерть и БЛД как комбинированный такой исход, в этом метаанализе их разделили и фактически что сделали? Практически в 2 раза сократили число наблюдений. Из-за этого, соответственно, могли поплыть и статистические параметры, такие как доверительные интервалы. Ну и добавлены были в это исследование, там турецкое исследование, где парактант вводился там в дозировках и 100, и 200, и там не было разделения на эти дозировки, и сравнивал с бирактантом, что тоже, в общем-то, несколько размывало показатели. Но на что я хочу обратить внимание, что даже при этих вводных, вот посмотрите, там смертность 28 дню, посмотрите на нижний доверительный интервал 0,98. Это очевидная тенденция к достоверности, и это больше похоже на, ну, на статистические нюансы. Такая же картина и касается бронхолегочной дисплазии. И понятно, что если эти два исхода объединить, то достоверность будет совершенно очевидная. Но если мы посмотрим, это тот же самый метаанализ, если мы посмотрим исход такой, как БЛД, у детей, которые получали сурфактант, вот здесь написано в соответствии с протоколом Соединенных Штатов, это значит, что стартовая дозировка была 200 мг на килограмм, то мы увидим, что доверительный интервал нижний, он единица 0,0. Но что мы знаем из курса статистики? Не бывает нижнего доверительного интервала единицы. Это значит, что она бывает либо меньше единицы, либо больше. То есть это значит, что 1, 0, 0,8, 0,09 и так далее. То есть которые просто округляли до привычных цифр. Другими словами, если посмотреть на этот метаанализ, то можно и посмотреть просто на цифры, то видно, что вероятность БЛД в 1,5 раза ниже при использовании бирактанта, извините, при использовании парактанта альфа. И поэтому на сегодняшний день у нас с вами, у нас на сегодняшний день, я считаю, что вот те рекомендации, которые были опубликованы в 2019 году, они их исследуют, собственно говоря, их исследуют использовать. Я не буду повторяться уже за неимением времени. Вот, пожалуй, что и все, что я хотел сказать по блоку родильного зала. Спасибо.
Thank you very much for possibility to attend this meeting. I will try to speak English, so sorry to interpreters and to those of my Russian colleagues who are listening to this session. And thank you very much for Scientific Committee for this possibility to attend this very highly respected international meeting. I'm participating in this meeting for several years, and every time it is pleasure. It was special pleasure when this neonatal and perinatal forum moved from one city to another. But unfortunately, with pandemic, we have to do it online, and it is an excellent possibility not only to talk, but to see my friends, unfortunately online, but it is nevertheless, this is an opportunity. And the subject of my talk is how to prevent the lung injury in an ICU, and we'll focus especially on the ventilation. And I would like to start my talk from the story, and I would like to remind all of you that the artificial ventilation is quite a new technology, and it was initially invented into routine medical practice in the previous pandemic of poliomyelitis, which happened in Europe in late 50s. And there were several technical devices which were invented at this time. This was special bed. And when the person when the head of the person goes down, the diaphragm goes up, and it mimic the expiration. And then when legs goes down, the diaphragm goes down, and it mimics the inspiration. And this is a device which calls an iron lung. And when I was a medical resident, I remember this machine in one of our units. It never works, but it was in the corner, and it was like a museum. And this is a picture of NICU in the United States of America in early 60s and during the pandemic of poliomyelitis. And it looks more like a plant factory than a medical institution. And approximately at that time, the first experiments, the first trials with neonatal ventilation happened, and very early in this course of neonatal ventilation, in 1967, there was a famous paper published by William Northway with the co-authors, which calls pulmonary disease following respiratory therapy of hyaline membrane disease. And it was the first paper when it was described the disease, the consequence of ventilator-associated lung damage. If we go to the details, we can see that Northway, the group of patients which was described by Northway was survived baby with average body weight of 2,200 kilos, 2,200 grams, and the mean birth weight of infant who dies was 1,600 grams. Now most of this baby will easily survived and had no any kind of lung damage. And if you look at the technique of ventilation, we can see that there was tremendous peak pressure, almost no PEEP. There was routine suction of the endotracheal tube. Every 48 hours, those babies was reintubated without any reasons. And all of infants was not firm. They all was in spine position because there was a danger of dislodging an endotracheal tube. And all babies ventilated with the very high percent of oxygen. And it was a very important observation. And the second important paper, the second important observation from the past was an observation which was made in the United States, in Texas, on the military air base of US Air Force. And this observations was made by the team led by one of the first American neonatologists, Professor Robert DeLemos. He was a colonel of American Air Force. And this study was done on Wilford Hall. This was a military air base of American Air Forces. And it was made with the baboons Papiaceanus. They was delivered in 140 days of 180 days of complete gestation. So it was 80% of gestation. All baboons was delivered by C-section, and they all was born with surfactant deficiency, and 99.5% of them developed the RDS. And this is a picture from an NICU for baboons in the Wilford Hall Hospital. And you can see that it was really an NICU with temperature control, with infusion, with TPN, with measuring blood pressure, with X-ray. And this was the study comparing conventional ventilation with high-frequency ventilation. All baboons was ventilated for several days. Then they were murdered, and investigators made electronic microscopy of the lungs, comparing the lung damage from conventional ventilation, sorry, or from high-frequency ventilation. And what we knew from the study that those baboons who died very early in the course of the disease had no signs of RDS in their lungs. So we can conclude that RDS is not an inborn state. At birth, we have only immature surfactant deficiency lungs. And RDS, which we also called hyaline membrane disease, is the disease of damaged lungs, and the tidal volume ventilation may cause damage of surfactant deficiency lungs. Of course, when we faced with this lung damage, with this, how it was called by Northway old BPD, we deal with a quite bigger baby, and the signs of this old BPD was the collapse of alveoli, was squamosous metaplasia, necrosis of the epithelium, inflammation, and airway collapse. Of course, it was in pre-surfactant era, but unfortunately, in post-surfactant era, we still face with another disease, with another consequences of lung damage, which was called a new BPD by Alan Job. And anyway, we have to be very cautious, and we have to look for an optimal way how we can prevent the lung damage in these immature babies. And if you look at this meta-analysis done by Italian team, by Gianluca Lista and published in Archive of Child Disease in 2010, we can see that
Марк Евгеньевич, помедленнее, пожалуйста, умоляю.
We can see that prolonged lung ventilation is still one of the main causes of lung injury. And as longer the ventilation, as bigger the probability of lung damage in premature infants. We have to understand what is going on and to make a special way to prevent this disease. We have to go back and remember this picture, which is volume pressure curve of lung disease, and we can see that we have a low zone of this curve, the zone of lung collapse, and the zone of J-recruitment, which causes lung damage. And we have an upper zone, a zone of overdistension, which is also damaging the lungs, which is a volumetrauma. And we have safe windows where the lungs are quite stable and safe, and where the lung damage is really very minimal. And it is just from our school textbooks that if we use an appropriate PAP but insufficient positive end expiratory pressure, we have big areas of collapse, and lungs expanded during the inspiration, but they collapsed at the expiration. And this lungs requires a lot of pressure to inflate, and then they collapsed on an expiration phase anyway. When we have an appropriate PAP and appropriate positive end expiratory pressure, we have quite a normal lungs, and we can see that the tidal volume, while the PEEP is normal, becomes bigger, and we need less pressure to maintain an optimal lung inflation. And if you have excess PAP and sufficient end expiratory pressure, we can see that we could maintain optimal inflation of the lung at the expiration phase, but on the inspiration phase, we have oral overinflation, and which cause also another way of lung damage. If we try to discuss the modern way to prevent the lung damage, of course, we have to talk about the volume targeted modus of the ventilation. This is special clever modes of ventilation which are operated by a microprocessor when the machine measures lung volume and inspiratory pressure and expiratory pressure and inspiratory time. And when the machine measuring lung volume during the inspiration and changes, when the machine measures the lung volume during the expiration and then changes the inspiratory pressure during subsequent inspiration to try to maintain the inspiratory volume or expiratory volume as we set up on the machine. Optimal volume was set in this case as 6 milliliters, and we can see that the machine started from the bigger volume and gradually decrease inspiratory pressure while reached an optimal volume which was preset by the operator on the ventilator. What do we know about the volume targeted ventilation? We know from the meta-analysis which was published in Cochrane review in 2017 by Dr. Klinenberg, Professor Colin Morley, and Professor Peter Davis. It was really an international team. We see that combined outcome of death and bronchopulmonary dysplasia in 32 weeks of gestation was lower in the volume targeted ventilation group. We also can see that duration of positive pressure ventilation was lower in volume targeted ventilation too. And we can see also that the failure to adjust the settings, the failure to provide an optimal ventilation during this ventilation in infants, the failure of treatment was also higher in the volume targeted group. And so now an issue is not to use or not to use volume targeted modes, but an issue is how to use volume targeted modes and how to avoid this treatment failure while we use volume targeted ventilation. And there are several very practical issues which I would like to focus on. And the first issue is when we use the volume targeted modes, we shouldn't use very low volume guarantee tidal volumes. And this is a very elegant paper published in 2006 by a group from Gian Vocalista from Milan, where they shown then when we use volume guarantee of 5 milliliters per kilo, we had significantly shorter length of the ventilation compared to the volume of 3 milliliters per kilo. What is the reason? The reason is that we ventilate a lot of dead space in newborn with RDS, and when we use the 3 milliliters per kilo, we have a lot of dead space ventilation, but we don't appropriately ventilate an alveoli, and we don't provide appropriate gas exchange. So we should use a little bigger volume settings, for example, 5 cc's, not less than 4.5 cc's per kilo. Another trick with volume targeted ventilation is we should provide enough limit of positive of inspiratory pressure and enough flow to deliver an appropriated tidal volume dependent on PIP, which is necessary to provide appropriate tidal volume and compliance of the lungs and the patient effort. And one more reason which we should point out is that we should avoid a leak around in the tracheal tube when we use the volume targeted modes of the ventilation. And if we have a really big leak around in the tracheal tube, we should use either the system of leak compensation, or we should use the system of, or we should use a bigger size of endotracheal tube. Or if we can't use a bigger size of endotracheal tube, or we can't avoid the leak around in the tracheal tube, we should switch to pressure control ventilation and don't use, unfortunately, the volume targeted modes. And these are recommendations coming from Professor Martin Kessler. He's one of the inventors of this volume targeted modes. And his recommendation is to use in the most of the states from as an initial tidal volume from 4 to 4.5 cc's per kilo, and initial pressure settings is dependent on the states from 18 to 24, 26, and sometimes, for example, in term babies with meconium aspiration syndrome, up to 30 centimeters of water. And another important thing when we talk about the assisted ventilation, Many times when we go to the bedside, we see the babies on an assisted mode, but when the pressure settings on the ventilation is 40 per minute or 50 breaths per minute. And this is a very interesting study, which was published in 2020 and came by a group of Colin Morley and Stuart Hooper, shows that an efficiency of triggering and successful of triggering was much higher when we use a mandatory rate of 30 than when we use a mandatory rate of 40 and 50. So we should not breathe for the patient. We should assist the patient to breathe. And so it is really very important to use quite low rates when we use an assisted ventilation and when we can see the spontaneous effort of our patient. High-frequency oscillatory ventilation is a very promising method, and this is quite recent Cochrane review coming from Philip Koos from Belgium, when they shown that high-frequency ventilation comparing conventional ventilation showed very marginal but benefit, statistically significant benefit in terms of chronic lung disease comparing to conventional ventilation. And this is another part of the study. There was a significant decrease of retinopathy of prematurity in the high-frequency group. High frequency is quite a well-known technique, and I don't think that there is any reason to talk how to set up the machine with the high frequency mode. But I would like to say just a couple words about quite new mode, high frequency ventilation with the volume guarantee mode. It is really not well known and not widely used mode of the ventilation, but an interest to this mode can be explained by the quite physiological studies coming from Spain, coming from the group of Sanchez Luna, where they, in the very elegant study, showed that when we use quite high frequency of high frequency ventilation in volume guarantee mode, we can see that on higher frequencies the efficiency of CO2 removal was much significantly better in the volume guarantee high frequency ventilation than to normal, to the conventional high frequency ventilation. I don't know how, what term should we prefer, what term should we use. And this is another graph from the study, and we see that when the frequency of ventilation became higher than 12 Hertz, we can see much more efficient CO2 removal on volume guarantee high frequency compared to high frequency without volume guarantee. Unfortunately, there is no good clinical studies about the volume guarantee high frequency ventilation, and I think we are waiting for the studies in quite near future. And let's see that it is a promising mode. And on the slide there is an algorithm how to set up the machine when we use high frequency with the volume guarantee. NAVA is also a promising mode, and I think that all of us we use the flow sensor, and we faced many times with the phenomenon of auto-cycling of the ventilator. And McKee decided to make an elegant decision and to measure the electrical impedance of the diaphragm and fixing the electrical impedance of diaphragm and setting up the assisted ventilation based on these signals. And they have quite a complicated algorithm of how the machine is managing these signals. But unfortunately, it is a study from Japan published in 2018, which couldn't show any significant difference in rate of BPD and total duration of the ventilation when we compare NAVA or conventional forms of the ventilation, and also they couldn't show any difference in terms of sedation use of fentanyl and midazolam use. Non-invasive respiratory strategies, just a couple of words. This is a very recent meta-analysis published in 2020, which shows us that non-invasive positive pressure ventilation is superior to conventional CPAP in the prevention of chronic lung disease. BiPAP modes, which we widely use in our unit is also superior to conventional CPAP in terms of chronic lung disease, and but high flow nasal cannulas, comparing to conventional CPAP, couldn't show any difference in terms of chronic lung disease, at least in this meta-analysis. Surfactant is always an important issue to prevent lung disease, and I would like to show meta-analysis that LISA technique can also decrease the lung damage. And of course, LISA is mostly the technique for the delivery suite, but sometimes in our unit we do LISA in NICU when the patient is admitted to the NICU from the delivery suite, and it is a very important technique. And I would like to finish my talk and give some take-home messages that the volume-targeted mode should be the mode of choice for premature infants. It is not a question to use or not to use the volume-targeted modes of the ventilation. The issue is to be successful in volume-targeted modes, and we briefly discussed what can we do in order to achieve it. Volume guarantee high frequency oscillatory ventilation is attractive and potentially useful method. Optimal method of CPAP is still a subject of future studies. Optimal surfactant therapy is an important way to prevent lung injury, and we should support non-invasive ventilation or any non-invasive techniques whenever it's possible to avoid the lung damage and prevent chronic lung disease. Thank you very much.
Thank you very much, Mark, for your excellent presentation. We'll just move straight on to mine, which is pre-recorded, and then hopefully we'll be left with some time at the end for questions from everybody.
Thank you, David.
Okay, good afternoon, everyone. My name is David Sweet. I'm a consultant in Belfast in Northern Ireland. I'd like to start by thanking Ursula Sturm for organising this meeting, giving us the opportunity to meet during COVID in this virtual way. Begin by just giving my disclosures in the usual way. In the past, I have received speakers' fees from AZ Pharmaceuticals, from AbbVie, from Jaeger, although I don't own shares in any of the companies, nor do anybody of the companies influence anything that I have in my lectures. Between the three of us, we've been asked to cover lung protection strategies from birth to discharge. We all know that there are many different aspects to lung protection, beginning before birth. Hopefully, Prof. Einoff will have covered strategies in the delivery room to protect lungs, and Professor Putkin was going to go through some of the mechanical ventilation strategies to protect the lung. And I've been tasked with going through pharmacological strategies for lung protection, which again is another very important area for consideration. Why do babies get BPD? Well, it's now very clear that a combination of factors, including prematurity, exposure to mechanical ventilation, which overstretch the lung, along with oxygen free radical exposure, oxygen toxicity, perhaps with additional infection, all have a final common pathway of leading to lung injury and inflammation, which in turn attracts neutrophils, and the neutrophils act in the lung, causing lung remodeling and fibrosis. And this whole spectrum of what goes on is a process which can be modified by things that we do, and the whole emphasis in neonatal care is going to keep as many babies alive as possible while trying not to cause lung injury. In terms of pharmacological strategies, there are things that we can do in terms of trying to reduce the amount of time on mechanical ventilation. There are considerations about means of using pharmacological strategies to try and reduce oxygen toxicity. There are ways of tackling inflammatory response. And there are other considerations, things that can happen which can influence lung injury, like babies having atypical infections or babies with large patent ductus arteriosus. So all of these things need to be considered when we're caring for preterm babies at risk of BD. So beginning with prevention of lung injury, hopefully Professor Einov and Professor Prudin have emphasized that if possible, it's best if we completely avoid mechanical ventilation. And the way that we do this is to have strategies in the delivery room for CPAP. If we need to give a surfactant, we use less invasive surfactant techniques. We tolerate a moderate degree of hypocarbia. One of the key strategies that we have in our armamentarium of drugs that we use is caffeine. And I'm going to go through the next few slides explaining what the recommendations are for caffeine and why we have come to those conclusions for the recommendation in the most recent European guideline. So if we look at the 2019 European RDS consensus guideline, the current recommendations are that caffeine should be used to facilitate weaning from mechanical ventilation. A1 means there's strong evidence and a strong recommendation. And it also says that early caffeine should be considered babies at high risk of needing mechanical ventilation, such as those infants on non-invasive respiratory support. But if you look at the recommendation now, the evidence is only grade C, although it is still a strong recommendation. And I'll go through why this grading has appeared the way that it does. If we're looking for evidence, one of the first places we can go to is the Cochrane database of systematic reviews, and there are several Cochranes which are involved with looking at methylxanthine therapy for various aspects of neonatal care, including treatment of apnea, for reducing the risk of extubation failure. There's comparisons between various methylxanthines, and we'll just go through some of the analysis from these Cochrane reviews. The first one is looking at the role of methylxanthine for apnea reduction. You can see the meta-analysis shows you that there's 5 trials. Some of them are using theophylline, some of them are using caffeine. When you put them all together in meta-analysis, you can see that both theophylline and caffeine will reduce the risk of apnea by about half. And this is statistically significant difference. So clearly methylxanthines have a role in prevention of apnea in preterm babies. What about babies who are being extubated and treatment with methylxanthine to prevent them from requiring reintubation? This Cochrane review looks at prophylactic methylxanthines for endotracheal extubation in preterm babies. Some of the studies using CPAP was routine, and some of the earlier studies using CPAP was not routine. And some of the studies again used theophylline and some used caffeine more recently. But you can see you put all of the studies together, there is significant reduction in the need for reventilation if babies are on methylxanthine therapy prior to extubation. So about a halving the risk of needing reventilated, and it is statistically significant. There was a couple of small studies which directly compared the effect of caffeine versus theophylline, and these studies are quite old now, one in 87, one in 82, very small studies, but you see when you put it together, you can, looking at the outcome of apnea, you can see that caffeine and Doflin have a relatively similar effect. Caffeine appears to have a similar short-term effect on apnea bradycardia to Doflin, but in view of other therapeutic advantages of caffeine, higher therapeutic ratio, more reliable enteral absorption, and a longer half-life, caffeine is the preferred treatment for apnea preterm infants. So although the studies are all looking at both types of xanthine, really caffeine is one that we should consider because it's much safer and easier to use. Most of the evidence that we have for caffeine use still comes from the CAP trial, which is now more than 15 years old, but it was a really beautiful study. More than 2,000 babies, 512.50 grams, who were less than 10 days old at the time of recruitment, were randomized to receiving caffeine or placebo to treat apnea or to facilitate extubation. And the study was designed to long-term outcomes at 2 years because there were concerns about exposing small babies to drugs which stimulate the brain. And you can see from the CAP trial, maybe 1,000 babies in each arm, done blind, and the baby received caffeine, came off the ventilator a week earlier. They came off CPAP a week earlier. They came off oxygen a week earlier, and they had a significant reduction in the rate of oxygen dependency at 36 weeks and less use of steroids or BPD. And the babies were then followed 2 years, and they showed that rather than having a worse long-term neurodevelopmental outcome, that caffeine exposure seemed to improve their long-term neurodevelopmental outcome. This was believed to be secondary to the reduction in BPD, was known to have an adverse effect on the developing brain. So this is why the recommendation for using caffeine to facilitate extubation is one evidence. But got to remember the CAP trial wasn't looking at prophylactic caffeine. It was studying babies who had apnea or babies who were coming off mechanical ventilation. So what can we say about just routinely using caffeine for preterm babies to try and prevent apnea? Why should we recommend routine caffeine? There is an absence of good quality large randomized trials exploring this question. These trials may never get done now because people actually believe that caffeine is a good thing to use and would find it hard to be in equipoise in terms of randomization. But we can look for other types of evidence. There's a large cohort study published in Pediatrics 2014 by Dobson. It looked at a very large database of babies, and these babies were discharged over a 13-year period. They looked at babies less than 1,500 grams who had received caffeine, who hadn't died. Then, using this database and propensity score matching, he had 29,000 infants, half of whom had received caffeine before 3 days and half of whom received caffeine after 3 days. And he wanted to examine the relationship between the timing caffeine initiation and outcomes such as BPD or death, as well as other outcomes. And also over that time period, characterize the changed use of xanthines. In this database, it's the same evidence as randomized trial, but it is important nonetheless. We had 14,500 babies, and using propensity score matching, we had a group of 14,500 who were of similar gestation and weight and similar maximum FiO2 on day 1. And he's able to show that babies who got the caffeine earlier had less BD and death, they had less retinopathy of prematurity, they had less treatment of PA, and less intraventricular hemorrhages. And with the 13-year time period, he was able to show that clinicians were starting to initiate caffeine earlier and earlier, from an average of the 4th day of life in 1997 to the 1st day of life in 2010. So although this is a randomized trial, it does give us some assurance that recommending treatment with caffeine early is probably safe, maybe doing some good. There have been a few randomized controlled trials exploring early caffeine, and there's this recent meta-analysis published in the British Journal of Pharmacology 2013, where all of the studies looking at early caffeine versus placebo have been put together in meta-analysis. So there's nearly 1,000 babies in 2 studies, and you can see that early caffeine does seem to be better than later caffeine in terms of reducing BPD, with about a 3% reduction in the outcome of BPD. So in summary then, we can say that methyl-xanthines reduce apnea. They also increase the chance of successful extubation. Caffeine is as efficacious as theophylline, but safer and easier to use. Caffeine reduces the overall time ventilation and reduces BPD. And longer-term follow-up suggests that you get better outcomes in 2 years, probably on the basis of less BPD. And giving caffeine early appears safe and is associated with less BPD. Okay, moving on then to the next subject I want to consider in our pharmacological approaches to lung protection, or the issue of antioxidants. It's known for many years that preterm infants have lowered antioxidant defenses, and these only start to develop as an infant approaches term. And in the past, there have been studies looking at the role of supplementing various antioxidants to try and boost the baby's lack of antioxidant response in order to try and prevent lung inflammation. And the main drugs that have been studied include vitamin A, vitamin E, and intratracheal peroxide dismutase. And I'm going to ignore the last two because the studies of vitamin E were inconclusive and didn't really show any benefit. And the studies of intratracheal SOD also showed no benefit. However, there have been studies on vitamin A which have shown that this vitamin or this drug can influence the outcome of BPD. This is a Cochrane review looking at vitamin A supplementation to prevent mortality, showing longer morbidity, very low birth weight index. You can see there's been around 5 studies done over the years, and we put them together in systematic view, looking at the outcome of chronic lung disease at 36 weeks. You can see that vitamin A does have a statistically significant reduction in BPD. However, the reduction is fairly modest, around 13%, and to get this benefit, the vitamin A has to be given a regular intramuscular injection. So many clinicians feel that to get this very small benefit, have to expose babies to all the pain of regular intramuscular injections probably isn't worthwhile. Although this is one of the few treatments that have directly been shown to have an effect on the outcome of BPD. And if we can't tackle ventilation and can't tackle the oxidative stress, is there a way of actually tackling the inflammation itself? And of course there is, that we have the ability to use corticosteroids to suppress inflammation. So sort of consideration that we have for steroids are, which steroid should we use? Should we use systemic or inhaled steroid? And of the steroids that we have, there's dexamethasone and hydrocortisone. For to use them, what dose should we use, and when should we start treatment? And these are all the things that have been studied in randomized controlled trials. If we look at the most recent European RDS consensus guideline recommendations from 2019, this is what the group has said about the use of steroids for lung protection. A short tapering course of low dose or very low dose dexamethasone should be considered to facilitate extubation of babies who remain in mechanical ventilation after 1 to 2 weeks. So strong evidence, but not a strong recommendation. And then the next one is to say that inhaled budesonide can be considered for infants at very high risk of BP. So strong evidence, but not a strong recommendation. So I'll go through what evidence there was, try and guide these recommendations, why they haven't made strong recommendations saying you must do it, but you should be considered. Okay, so beginning with the question of using steroids early or tackling the problem by routine giving babies early corticosteroids, does this help? There's been many studies done looking at early steroids to try and prevent BP, and you can see this meta-analysis from Cochrane 2017. Most of the studies are trending towards showing a reduction in BPD. When you put all of the studies together into analysis, there's nearly 1,300 babies in each arm, and you can see the far top lies to the left, the line of unity. So early steroids do have a significant effect in reducing the outcome of atherosclerotic lung disease. So why don't we just routinely give babies steroids to try and prevent BPD? Well, several years ago, it was picked up by Ye and colleagues that if you look at other outcomes in the meta-analysis, it's not just as straightforward as it seems. Steroids are powerful drugs, and they have many associated side effects, both short and long term. Short-term side effects include things like hypertension, hyperglycemia, gastric perforation. But if you look at long-term outcome, which is what would be important to neonatologists, one of the things that caused concern was that they give these steroids you cause a significant increase in the risk of a baby developing cerebral palsy. When it was first discovered, there was almost a complete cessation in the use of steroids to prevent BPD. And as a result, probably many babies who may have benefited from this therapy didn't get it because clinicians were so concerned about this finding. And this may all be to do with the timing of steroids. If you look at the meta-analyses of dexamethasone studies for babies more than 1 week of age, these also show a reduction in the combined outcome of death or BPD without the negative impact on long-term outcome. Just to go through this, the Cochrane does divide babies in early and then into late steroids. So this is a separate Cochrane review looking at late systemic steroid for prevention of BD. This is a meta-analysis, again, many studies that have done looking at this. And again, you can see a significant reduction, about a quarter of less babies will BPD if they're given steroids beyond a week. And when you do the long-term follow-ups, just looking at the outcome, death or cerebral palsy, this no longer shows a statistically significant impact. So perhaps for babies getting later steroids, you might get the benefit of reducing BPD without exposing the baby to much risk of disimproving their long-term neurological outcome. How does this happen? Well, this is a very clever study which is published by my colleague, Professor Halliday and Lex Doyle in the Journal of Pediatrics 2014. They looked at all of the studies where they had follow-up data and BPD data, and they were able to show that in studies where the rate of BPD in the control arm is high, then you've got more benefit than harm from steroids, where the rate of BPD in the control arm was low, you get more harm from steroids. This is saying that the higher risk of BPD, the more benefit is achieved from steroid use. So we should reserve steroid use for infants who are definitely heading towards BPD, such as those babies that are stuck on ventilators beyond the first 1 to 2 weeks of life. Then obviously the logical conclusion of that is if steroids work, what about using the gentle topical steroid or inhaled steroid? Do these work? When you look at the Cochrane review for evidence about steroids to reduce BPD, you can see there is a Cochrane review, but unfortunately the number of studies looking at this was very small. In fact, when you look, there's only been a total of 15 babies in the Cochrane review, and showing no difference in outcome of using prophylactic or steroids to reduce BPD, beyond 7 days of age. Recently, there was the very large study of prophylactic inhaled budesonide to try and prevent BPD, called the Neurosis trial. So it was in 863 preterm babies under 28 weeks gestation plus administration of an budesonide from birth until 32 weeks corrected or until they come off oxygen, compared with placebo, influenced the constant primary outcome of death or BD by 36 weeks corrected gestational age. And it's published in 2015. I'm sure you're familiar with the data from this trial. They were able to show that giving budesonide did result in a significant reduction in the outcome of BPD, but there was a trend towards an increase in mortality, which made them a little bit nervous about recommending routine budesonide use. It must be said that this statistically significant obesity outcome like mortality is a very low event rate. So you can potentially use inhaled or nebulized budesonide, but you just got to be a little careful about maybe doing it too often because there may be a downside as well. And then even more recently, people have explored using the budesonide mixed in with surfactant for very weak terms. There have been 2 trials, both of them from China, nearly 300 babies studied between the 2 trials. Look at them in meta-analysis. There's a 43% reduction in PD with the number needed 3 to 5, with no significant mortality difference. The 40% reduction in the combined outcome of death or PD. Some centers have started doing this routinely already, but my own belief is that we need more research on this, maybe studies from other countries and larger trials to see if this is truly the forward to give your budesonide along with your surfactant. So in summary, if a baby is on a ventilator beyond 1 week of age and you've excluded other causes of being on a ventilator, such as infection or a large PDA, then you should use dexamethasone with the aim of facilitating exudation. And in my hospital, we use a DART regimen, which is 60 micrograms per kilo BD, which then tapers over 10 days with the aim of extubating during the steroid course. And if an infant is stuck on CPAP, showing evidence of evolved severe BP, such as an FiO2 greater than 0.4 with typical lung changes on X-ray, then we should start budesonide nebulizers to try and modify the course and potentially prevent prolonged oxygen dependence. And what are pharmacological considerations are there? Obviously, there's the issue of whether a large duct influence BPD, and that's a topic for a whole other day, whether managing the duct can prevent BPD. And we also know that some infants with evolving BPD, if you send secretions for special culture, they will grow atypical organisms like ureaplasma and mycoplasma. So if we've got a baby with BPD, it's worth screening for these organisms and, if necessary, treat with clarithromycin. There are studies now looking at the role of azithromycin, which is anti-ureaplasma effects, also has anti-inflammatory effect. The Aztec trial is currently underway to see if azithromycin can prevent BPD. And some infants with severe BPD, treatments for pulmonary hypertension may be needed, but I don't have time to go to all of those today. So I'll end there and wish that next year we can all meet in person again. And in the interim, I'll show you some pictures from where I live in Northern Ireland, and hopefully at some stage in the future when we can all travel, some of you can come and visit me here. All the best now. Thank you.
Okay, so thanks for listening, everybody. And we've got
David, unmute.
okay, sorry about that. It's unusual for seeing my lips move with no sound coming out. Thanks for that. We're now at the end of the 3 speaker sessions. We've got the next planned session is going to be case presentations starting in 20 minutes. we'd like 10-minute breaks. So we've got 10 minutes for discussion around any of those topics. Perhaps but the other panel members can help me kind of moderate this, but I did see as Professor Prutkin was presenting, there was a question for him from Ram. HFOV as a primary mode of support has not been shown to decrease BPD when compared to conventional ventilation. Any comments on that, Professor Prutkin?
Let me switch to an English channel. Well, if we look at this meta-analysis, it shows very marginal benefits of high frequency on the very border of significance. It's from the one hand, and from the other hand, I paid attention that all of the studies which shows any benefits of high frequency ventilation was done on sensor-medic machines. And all studies which were done on Draeger machine, on SLE machine, and any other machines didn't show a lot of significant difference. So maybe the type of machine and the method of generating the oscillation take makes the difference. What do you think, Ram?
Do you recommend as a primary mode of respiratory support in your NICU for preterm baby with RDS, high frequency ventilation?
We don't use the high frequency as a primary mode. We use it only as a rescue mode. We used to use the high frequency as a primary mode for babies with the diaphragmatic hernia, but we stopped doing this about maybe 2 years ago, maybe 1.5 years ago. And we could see that our results become better. So no, we use it only as a. We used to have about 7 to 8% of our ventilation on high frequency machines, but during the last 2 years we have a decrease to, let's say, 5% or something like this. Alex had some comment.
Yeah. I would like to show you do you see it? Do you see the slide? Yeah. Yes, I would like to show you that in systematic review, elective high frequency ventilation versus conventional, that it is a very interesting thing that if you apply high frequency ventilation within this hour, not later 4 hours, you can see decrease of death or severe adverse neurological events or death of BPD. This effect was not seen if you apply high frequency later or earlier. So I think that it is an interesting thing, and we can just think over about it. Because in our department, we now we provide randomized trial babies, but late preterm babies who are failed of CPAP. One group received Curasuf, Poractant, another group received Beractant, another group received Alveofac, and another group received just high frequency ventilation without surfactant. And primary results, we didn't see any differences. So the primary high frequency ventilation could be applied, I think, if we see to the trials more deeply.
How many patients do you have in each of your group?
More than 100, I think now. I should ask.
100 in each?
Yeah. No. Approximately 40 in each.
I think if you look carefully at the Cochrane review, you'll see that there is a significant reduction in the outcome of death or BPD favoring HFOV at the minute. But the problem is that many of the trials are very old and they were using non-volume ventilation in the control arm. So it's very difficult to look at these data altogether as a big group. In my unit, we don't use elective HFOV except if we think there's potentially very high risk of chronic lung disease in an infant, perhaps with prolonged rupture of membranes for many weeks. There has been a randomized controlled trial specifically looking at babies with diaphragmatic hernia called the VILI trial, and it showed outcomes were better if you use conventional ventilation than HFOV. So again, we've switched to moving conventional ventilation for babies with diaphragms in our unit as well. I'm just quickly going to move on because there's a question that appeared in Russian in Q&A and somebody's kindly translated it. So what's our opinion on the doses of caffeine? What's the maximum dose, and should caffeine be administered in the delivery room in preterm infants less than 32 weeks? So I'll start answering by saying we have a standard dose in my unit of loading with 20 and then 5 per kilo maintenance. Often it goes up to 10 per kilo in babies who have breakthrough apnea. There have been randomized trials comparing 4 times that dose, which is loading with 80 and then 20 maintenance compared with loading 20 and 5 maintenance, showing that you get less apnea with a higher dose, but more side effects. So nobody really knows the exact right dose to use for caffeine, but we would on occasions go up to 20 in our unit. In terms of using it in the delivery room, we haven't got there yet because we don't in our unit put IV access in the delivery room, but I know some people do this, and I don't know if any of the other panel members would like to comment on the use of delivery room caffeine.
Same as you in terms of caffeine, not in the delivery room, but early in the first hour or so, same dosing.
Yeah, Ram, I have a question. Unfortunately, I cannot activate my video, so I guess it's blocked also, but it doesn't matter. You hear me, right?
Yeah.
I am Virgilio. So the Dutch started, they did 30 patients or so, and they did this umbilical cord caffeine, which I'm sure you're familiar with. Then they lost a bit of enthusiasm, and then study by Miami with Amaro, Juno Pediatrics, that described side effects with a very early caffeine in a very sick, in a population of very, very sick preterm babies. And I guess that paper brought up some concern about the early caffeine also. How is the situation now, Ram?
I think in the US, most centers, over 75% of the centers surveyed that showed that are using caffeine, caffeine.
In the delivery?
No, not in the delivery room, in the first day, first few hours.
Yeah, we do so. But the question was more whether we should give it in the delivery room.
No, as David said, there's very limited data.
Well, I can see Catherine is online, now whether she's at her computer at the minute, but I believe in some centers in Austria and in Germany where they have this Lisa in the delivery room and prolonged skin to skin, that caffeine therapy is part of that package. I don't know whether you want to switch on and comment, Catherine.
Yes, I can also have audio only. But yes, we have no really data to prove it, but I think the success of non-invasive RDS treatment is really depending on early caffeine dose. So we routinely give it in the delivery room, but we have no really data proof that this is of benefit. But I think our LISA success is depending on the early caffeine. And I think in Germany, these data you see of avoiding mechanical ventilation, there it's also a package of LISA and early caffeine, usually.
But there is something, the Dutch, Arjan de Pas, and there's a pediatric research paper on 30 patients, they try in Leiden, delivery room via the umbilical. I was very fond of it because in principle, I do agree with you that if you get the extra coughing right away, you get better water clearance, you get better diuretic effect, stimulation, and so on. So it makes kind of sense. But I don't understand why the Dutch, at some point, they got a little bit more, they slow down and they're not enthusiastic any longer. And this paper from Miami, also not positive about that. So I can't really assess the cost benefit ratio of this operation in this very early coughing.
We've just got 1 minute left before we'll take a 10-minute break. I'm going to ask a final question of Oleg. The recent data that's come through from Arjan de Pas's group on the effects of face mask application in causing apnea, and how do you think this will influence your planned future work on using delivery room sustained inflation maneuvers? And I wonder if there's a school of thought which says that babies during delayed cord clamping should maybe just be left alone and breathing by themselves.
Sorry, David, I didn't see this question, and could you repeat it?
Yes, Arjan de Pas has
Sorry, you switched off microphone.
There is something wrong with your microphone. It's switched off just accidentally.
Okay, sorry about that. Arjan de Pas's group recently has published showing that applying a face mask can induce apnea. And we're now talking about what we do with an infant during the 60 seconds of delayed cord clamping. And from what your talk, you were suggesting there should be some further work on sustained inflation in babies right at the beginning of life. And I just wonder if there's maybe a school of thought that maybe some babies should be just left alone for the first minutes to allow them to stabilize by themselves.
Absolutely agree with you. When baby is on working cord, as we can say it. I mean, when we provide delaying of clamping, and if heartbeat is above 100, we absolutely don't worry about whether baby breathe or not, because all exchange mechanisms are going on, and it doesn't matter. And most of babies can breathe themselves without any maneuver, any sustained maneuver, so they don't need it. So that is why we start with, we're trying to start with cord clamping, delay cord clamping. But if baby doesn't breathe, instead of after we transfer from mother to respiratory, for respiratory some interventions, we in our, how to say, several years ago in our trial, retrospective trial, we start with sustained inflation, but single, not twice, only single one. If we don't see effect, we don't repeat it, because we understand that we can damage the lung. But and we start with mask ventilation. But now we start, we follow Catherine, and we start with just high pressure of CPAP. So to reduce the resistance of airways, and so baby can expand well, and if baby start breathe, baby could breathe through TP's connector. So.
Okay, well, I better stop you there, because it's now 23 minutes past, and we need to start again at past with the case presentation. So we've all got 7 minutes to grab a coffee and go to the bathroom. We'll see you back here very shortly. Thank you.
Thank you.
Okay.
Okay, thank you. Well, thanks everybody. I hope you've all got some refreshments in your hand. And the last session for today is 2 case presentations. The first presentation is by Dr. Mariana Marcin from Bucharest on bronchopulmonary dysplasia, still an unsolved problem.
Hello, good evening. My name is Mariana Marcian, and I'm from Romania, and I'm working in an neonatology department of Dr. Cantacuzino Hospital from Bucharest. First of all, I want to thank you for the great opportunity to participate at this meeting. I will present you a case of a preterm newborn baby with many prematurity complications, respiratory distress syndrome, pulmonary hemorrhage, Ehrlich syndrome, enterocolitis, and so on, and bronchopulmonary dysplasia with long-term pulmonary morbidities during hospitalization in our neonatal intensive care unit. Bronchopulmonary dysplasia has continued to be a major complication of preterm birth. There are currently no clear recommendations for the treatment of the patients with BPD require intensive care. From the relevant history, it's about a male preterm newborn baby with 700 grams birth weight, 26-27 weeks gestational age with perinatal hypoxia. The baby was delivered by a C-section, emergency C-section for umbilical cord prolapse, transverse presentation with mother incomplete course of steroids, heavy smoker mother. She was during pregnancy, influenza contact, and also with hepatitis C. The baby was put on delivery room on CPAP, but because of agitation and desaturation, the baby was intubated with gas surfactant, and he was on invasive mechanical ventilation. We kept the baby on mechanical ventilation because he developed in the first hours of life pulmonary hemorrhage and 2 other episodes of pulmonary hemorrhage in the next 12 days. And he was on mechanical ventilation for 1 month because he presented a lot of complication with air leak syndrome, interstitial emphysema, and pneumomediastin, also neonatal seizure at 5 days of life, and necrotizing enterocolitis at 19 days of life. Here we have few of chest X-rays from the first month of life. This is from the first days, the second day of life, and the last one is after extubation. I put here the cranial ultrasound in the 5 days of life when the baby presented neonatal seizures. The mechanical ventilation was interrupted after 1 month of life, but the baby still need oxygen, supplemental oxygen in free flow in incubator, 25-35% till 4 months and a half. The baby was treated for BPD with fluid restriction, diuretics, inhaled steroids, and also bronchodilatators and caffeine. He was on full enteral feeding at 2 months of age and exclusively bottle feeding at 4 months of age, 42 corrected weeks. Clinical course, unfortunately, was unfavorable with 2 episodes of aspiration syndrome with increase of supplemental oxygen and needed high flow nasal cannula at 5 months of age, and aspiration bronchopneumonia after 2 weeks, and he needed mechanical ventilation, invasive mechanical ventilation, and he was ventilating NSI-PPV with high ventilatory settings. Also, we gave him nitric oxide and sildenafil. Blood culture was with Candida parapsilosis at 6 months of age, and on mechanical ventilation, the baby repeated aspiration bronchopneumonia at 8 months of age. Here we have the first episode of pulmonary aspiration bronchopneumonia. What went well? Remission of Candida infection with fluconazole and also remission of recurrent episodes of aspiration. And the baby in the last 3.5 months was on full enteral feeding. What didn't go well? Poor weight gain, 4.5 kilos at 10 months of age, 7 month corrected age, The baby was with severe pulmonary hypertension and reflux, and still on mechanical ventilation in 100% oxygen during the last 5 months, and also with the treatment with diuretics, inhaled steroids, bronchodilatators, and also sildenafil. What could we have done better? Maybe early systemic steroids, early evaluation and treatment of pulmonary hypertension, and also PDA, evaluation and treatment of reflux, tracheostoma. What we do different next time? Early steroids for prophylactic treatment of BPD, gentle ventilation strategy, high flow nasal cannula, high frequency oscillation, CPAP, early echocardiography, and sustained interdisciplinary consult. My question for the audience are there are any ways to predict and to prevent all these complications, and what is the best prophylactic and chronic treatment for BPD, and what is the optimal treatment for pulmonary hypertension for this baby with bronchopulmonary dysplasia, maybe prostaglandins or milrinone, and what is the best approach for the acute episodes of desaturation, mechanical ventilation, antibiotics, aspiration, nebulized treatment, and which would be the future and appropriate treatment for this baby regarding bronchopulmonary dysplasia, pulmonary hypertension, air reactivity, reflux, optimal nutrition, and last but not least, neuromotor and cognitive development. Thank you for audience, and I stay here for your questions and also for answer. Thank you again for inviting me to participate at this meeting.
Presentation. There's now 6 minutes for discussion. On the question chat session, there's a question from Professor Ramanathan. Don't know whether you want to just ask it, Ram, or do you want me to read it out to you?
No, I can ask for it. Mariana understands English, Marcian. And the BPD, when the baby is over a month or 2 months old, we generally, by the time baby has airway disease, tracheomalacia, I would have used a lower rate, longer inspiratory time, and a higher PEEP. When you were vent settings, it was like RDS management. So that's a comment. I don't know what you feel about that.
We have the ventilator. I put the ventilatory settings when the baby was aspiration bronchopneumonia and pulmonary hypertension. It's not at 5.5 months of age. We gave also nitric oxide and also sildenafil, and we tried more dose of surfactant for aspiration bronchopneumonia. And after that, we saw that the baby developed pulmonary hypertension. And we use these settings at 10 months of age. I put the settings of the 10 months of age.
Okay, thank you.
I have a question, if I can.
Yes, yes.
You hear me?
Yes, I hear you.
Okay. Well, it's a complicated story. But it seems to me this baby started with some problem at the very beginning also.
Yes.
Is this tree hemorrhage something that happens often, or do you have an explanation why?
I think the pulmonary hemorrhage, I don't understand what happened in the first hours of life. But after that, we saw PDA and treated PDA. But unfortunately, at the 19th of age, the baby developed necrotizing enterocolitis. And we keep the baby on ventilator for this reason. And we didn't start earlier DART or and just after that.
I agree with your comment. Possibly, being less invasive as possible and start the early corticosteroid could have been. This is especially, I mean, it's a rather sick baby from the very beginning also. So it is a difficult case anyway. I mean, it's no matter in any part of the world. Possibly, do you had some concern? Why didn't you start steroids a bit earlier? Was a concern because of sepsis, neck?
Yes, yes, for neck and for sepsis and for seizures, we are a little bit not to start. But now we learn from this baby, unfortunately.
Mariana, it's David Sweet here. I mean, to be fair, I think all of us would be in the same position if we have a baby who's on a ventilator, who is septic and has necrotizing enterocolitis. The decision to start steroids has a whole different threshold. And I'm sure that anybody that you ask on the panel will have in their own unit infants that have not been able to be extubated for whatever reason and that end up getting very severe chronic lung disease. It's just one of those unfortunate things for some babies that happens. I probably would have been with you. I wouldn't have been very ready to start systemic corticosteroids in a baby who's not otherwise completely well, because it's a big decision. And then if you have a perforation or something happens, then you almost feel like you have to take some responsibility for that occurring. So complex case, but I think all of us have cases like this.
No, I do agree. I mean, my question was more to ask whether what was the reason for the sake of discussion. But by all means, a complete case, I would have done the same.
And what about the pulmonary hypertension? What is the best treatment for this baby? Because we have just sildenafil, nitric oxide when the baby was pulmonary aspiration, but we don't have a lot of nitric oxide, and we continue with sildenafil. And our cardiologist said about milrinone and about prostaglandins. In adults, they tried prostaglandins, but we don't try it.
As far as I know, I'm sure I like to hear the comment of the other. Milrinone is not of any use because the prostaglandins are the extreme. It may work in extreme cases, but it's not to be given to any patient or so. The trick there is to prevent or to ensure a good lung status so you don't get secondary pulmonary hypertension also. This story also sounds me. There was any chorioamnionitis, any prenatal infection that you could sort of.
I don't know exactly. I don't have just inflammation. The mother, the culture of the mother was sterile, but the mother was influenza contact with the other child. He was in hospital, and also birth asphyxia, and the baby was growth restricted, and it was one more risk factor for BPD. I don't know if we can predict which baby will develop BPD, because at the same time I had a baby with 1 month of ventilation, and he didn't develop BPD. Unfortunately, hydrocephaly. But
this is a very interesting point. We are interested in this question of yours. I mean, because it's BPD, it's really a very difficult condition. Sometimes associated with lung hypoplasia, sometimes associated with inflammation, and so it's probably a syndrome. It's not a disease, and probably the etiology of the causes are multiple causes, or it may have different reason in different patients also for developing this type of syndrome, in my opinion. So that's a very difficult question. This is the reason why I asked about whether it was prenatal inflammation, because as far as I know, there are two risk factors for pulmonary hemorrhage. One is significant PDA, and the second is chorioamnionitis. So if you have chorioamnionitis and you think there is a significant inflammation, steroids may be something that could ameliorate inflammation, but it's on clinical ground. There's not much. What do you think, David or Ram?
I think we're going to have to stop the discussion there and move on to the next case if we're going to keep the time, if that's okay. Thank you very much.
Thank you.
Thank you.
Move on now to the next case presentation. It's Dr. Timea Brandenburg from Timisoara in Romania, who's going to talk about cholestasis syndrome in a newborn with early onset.
Good afternoon. My name is Brandenburg Timea. I am a specialist doctor at Luis Turcanu Hospital, neonatology department from Timisoara. I'm honored to be here and take part of this encounter. Summary of the case. We are talking about a term newborn admitted on the 10th day of life in our department, presenting the following symptoms: severe form of newborn jaundice, losing weight, repeated vomiting, severe maculopapular eruption on the face. I would like to mention that the patient was born in another hospital. He presented jaundice from the first day of life, which is why phototherapy has been met. Due to lack of jaundice improvement in the 10th day of life, newborn parents requested the newborn's discharge from the hospital where he was born on their own risk against medical opinion. Later, they came in our hospital's emergency service. We set the following diagnosis: syndrome of hepatocytolysis, cholestatic jaundice. After a closer observation of the patient, we also added the diagnosis of Niemann-Pick syndrome. As you can observe, the newborn's biological features at admission showed high levels of transaminases, total and direct bilirubin. The pregnancy was dispensary. The Gesta 4 and Para 4. A remarkable fact in the family history is that one of his brothers died at the age of 2 months, presenting severe liver failure, respiratory failure, cholestatic hepatitis, and sepsis. According to family's antecedents, we also found out that one of newborn's sister died in a fire. At admission, he presented in a relative good state with fever, poor feeding, jaundice, cardiopulmonary balance, liver touchable at 2 centimeters under the right rib, untouchable spine, normal urine and stool, maculopapular eruption accentuated on the face. From the 12th day of admission, he presented stool with alcoholic areas and dark urine. For etiological diagnosis, several samples have been collected and many interdisciplinary consultations have been carried out. In order to exclude the cause of infection, samples have been collected for B, C hepatitis, HIV, syphilis, cytomegalovirus infection, toxoplasmosis, herpes simplex, all being negative. For endocrine metabolic disorders, we have collected alpha-1 antitrypsin, ESH, galactose, all results being normal. The results of biological investigations relieved high value of serum alpha-fetoprotein, tyrosine, specific neuronal analysis. Hepatic probes profile maintained elevated for the entire at admission. The same thing happened with the direct and total bilirubin. Ferritin had a maximum value of 6,000 nanogram per milliliter with a continuous drop. Gamma GT varied between 120 and 72 units per liter. Interventions and treatment. Repeated abdominal ultrasound and gastroenterology consultations were performed, relieving no general modifications. Also, the cholangio MRI was normal and the sweat test was negative. So we excluded cystic fibrosis. Genetic consultation raised suspicion of inborn metabolic errors, and the Gaucher disease genetic test was negative. During the admission, a liver biopsy was performed, showing histopathological examination. Histopathological aspects and the performed coloration, which are suggestive for a lysosomal disorder, most likely the Niemann-Pick disease. Although the histopathological examination raised the suspicion of Niemann-Pick syndrome, the genetic examination for 2 genes tested was negative. Treatment. The newborn was fed with milk formula with no lactose. Caloric requirements was 130 kilocalories per kilogram per day. Carbohydrates with 10-12 kilogram per day, lipids with 3 grams per kilogram per day, and proteins with 2 grams per kilogram per day. We prescribed and administered treatment with ursofalk, aspartate, and human albumin. The particularity of this case lies in its family history of cholestatic jaundice. A newborn's brother deceased with cholestatic jaundice and severe hepatic impairment. What went well? I had a great collaboration with the multidisciplinary team, pediatric, genetic, gastroenterology, pediatric surgeons. Ultrasounds, guided liver biopsy, and histopathological examination guided diagnoses have been made. We also made multiple and complex genetic tests for inborn metabolic errors. Tests have showed a metabolic disease and lipid metabolism without being able to specify exactly the type of metabolic disease. Hepatic failure did not progress to cirrhosis until discharge. The nutritional support covered the increased metabolic consumption so that the patient presented a weight gain of 1 kilogram at discharge. What could we have done better? We did not proceed for larger investigation to determine any other genes involved in the Niemann-Pick syndrome appearance. And we did not repeat the liver biopsy puncture. For discussions point for the audience is what would you do on this case regarding the high level of serum transaminases and bilirubin and the moment of patient release from the hospital? And the second question is how would you continue to monitor this case? Thank you very much.
Thank you very much, Dr. Brandyber. Really excellent, clear presentation. I'm looking at my shoes with discomfort because in my hospital, when we get a complex liver disease baby, we just ask colleagues in Birmingham Children's Hospital in England to take over their care, and they do all the processing and investigation, so we don't have to think very hard. So I don't know what other panelists' experience is like of working through these. There's Oleg has his hand up. Off you go, Oleg.
Thank God, Oleg.
We also call the doctors when such cases happens, and I called to our colleague, and what they did say. That you didn't exclude Niemann-Pick correctly because gen examination are very complicated, and specific markers of Niemann-Pick, it is level of oxysterol. You should check oxysterol in blood, and LISA 5 or 6. It is specific marker of Niemann-Pick. Then my colleague said that it could be also Wolman disease. It is deficit of lysosome acid lipase, and you should check before biopsy. You should check cholesterol and triglyceride, and lipid profile, and you will see this metabolism and this in case of Wallman disease. And also you saw high level of tyrosine, and if you consider tyrosinemia, you should check succinylacetone in urine or in blood. Also, we should check the problem with beta oxidative of acid fats. And in this case, we should check acylcarnitine in blood. Also, it's looking like neonatal gamochromatose because, and you should exclude it because you see the high ferritin. And also we should check for neonatal lupus as well in the beginning of the disease. That is recommendation of our colleagues.
Thank goodness for Oleg and his colleagues. Can I ask you, is the baby doing well at present? Is it a recent case, or have you continued to follow them, or are they still very young?
Yes. What happened to our child? He was discharged on request and left for France, where he had lived before, and further investigations continued.
And you don't know the outcome of those investigations?
It's alive.
You have other rare conditions like familial progressive renal failure, bile salt disorder. They're all kind of metabolic conditions, rare ones that you can pick up with extended screening or with mass spectrometry. And there's no, the histology, the liver biopsy. I remember that you took one liver biopsy. Do you have what the pathologist says about that biopsy? Was specific or non-specific? Do you remember? Am I right? There was a liver biopsy at some point.
Yes.
Do you remember what the pathologist says? He was in favor of Niemann-Pick, right?
Yes, yes, it's true.
So means there are some, how can I say, some inclusion, some. Do you have the response from?
The histopathological aspects are suggestive for lysosomal disorders, most likely the Niemann-Pick disease.
Yeah, I'm not very experienced with that. Yeah.
The genetics for Niemann-Pick, however, was negative, isn't that right? So it could be a de novo mutation in that individual family. It's very difficult when you get these rare things that come along for people to be able to know all the answers. That's why I think specialists in hepatology units are often the people that help guide you through the various need for investigations. And it sounds like you've done that in your country and you've got the best help that you can. But unfortunately, the panel you have here today are mostly experts in neonatology rather than hepatology. So I don't know that, at least speaking for myself, I don't know that we're going to come up with any fantastic answers for you.
Yeah, I support that. In a case like this, you cannot manage on your own. You need to get the consultants like hepatologists, GI people. Yeah.
And it's now just gone 3 o'clock. I personally like to thank all of the panelists and participants for attending. I don't know whether Ram, you want to say anything, or any of the other panelists. No. I'll pass over to you now.
Thank you. I want to thank all the speakers and case presenters, as well as the attendees, for your active participation. I hope we learned from each other. I always learn when I attend a conference. So I hope it's useful, and have a good evening or a good night. For me, it's a good day. It's 7 o'clock in the morning for me. So we'll all see you tomorrow.
Okay, see you tomorrow. Thank you.
See you tomorrow. Thank you.
Thanks, Mark.
Bye-bye.
Thanks, Oleg.
Thank you.
Thank you.
thanks for the NPMF team for having this meeting without any problems today, technological problems. Artem, thank you.